Good morning, everybody. Incision is the first important step to a successful phacoemulsification. There are three aspects of the incision: shape. A square-shaped geometry is usually preferred. The location could either be superior or temporal, and the third aspect deals with instruments involved. A 2.8 millimeter square incision is usually preferred, as most of the conventional phaco tips and sleeve fits into it snugly. A square geometry withstands greater external pressure, improves wound integrity, resists leaking, and thus avoids endophthalmitis. The location of the incision could either be superior or temporal. A superior incision is preferable for the beginners, as most of the surgeries as a beginner he has performed is probably from the head end. The incision should be as far peripheral as possible. It should be anterior to the conjunctival insertion to prevent subconjunctival fluid accumulation and ballooning. A superior incision creates flattening of the vertical meridian, which is approximately 50% more than a similar temporal incision, and thereby it is said that the temporal incision induces less surgically induced astigmatism. There are three basic types of clear corneal incision: a monoplanar incision, a biplanar, and a triplanar. A single plane incision is a direct entry with a 2.8 millimeter angle slit knife into the anterior chamber. A two-plane incision starts with the initial groove with a number 15 Bart-Parker blade, and further advancement with 2.8 millimeter slit knife into anterior chamber. A triplanar incision starts with the initial groove with a number 15 Bart-Parker blade, followed by a lamellar dissection in the cornea with a crescent knife, and finally it is entered with a slit knife into the anterior chamber. The sideport incision ideally should be configured as a funnel, and the location of the sideport should be 2 clock hours away from the main port, as it increases maneuverability, minimizes leak, and minimizes striae. The sideport incision, if more than 2 clock hours, the second instrument, the chopper motion, becomes more of a sweep, and if less, then hand becomes crowded. At the end of the surgery, stromal hydration should be carefully done. Avoid detaching the Descemet's membrane, and assess the firmness of the globe and tightness of the wound. The instrument-related issues: a snugly fit phaco probe and incision gives a stable anterior chamber. A tight incision pinches the slip, and thereby the flow is reduced and the chamber becomes unstable. The ultrasound tip touches the incision, and heat is directly transferred to the stroma, gives rise to wound burn. Carefully look at this video. The parameters and the CDE, that is cumulative dissipated energy. See how quickly the anterior lips of the incision are becoming chalky white, and that is the first sign of the wound burn. See, it is becoming more and more chalky because it's a tight wound. And the end, there is a fish mouthing. The commonest cause of wound burn is tight wound. We need to ensure fluid flow around the tip before applying energy, and maximum burn occurs during tip occlusion and fragment removal, as it is a no-flow state. If you suspect a wound leak, put a suture to minimize wound margin or create a separate entry. Coming to the stop and chop technique, it was developed by the great Dr. Paul Koch. It is a combination of Gimbel's nuclear preparation and Nagahara's in situ chopping. First step is creation of space within the cataract, that is called trenching. Step 2 is cracking, and step 3 is chopping. The parameters for trenching is power according to hardness with a low vacuum and flow. For cracking, phaco probe and chopper is used to separate the nuclei into 2 halves, or you can use 2 Sinskey hooks. If fails, we can further deepen the trench specifically in the center and retry with the instruments. For chopping, A parameter, the power should be linear ultrasound or burst with high vacuum and high flow. And during fragment removal, the power should be micropulse with high vacuum and high flow. See, during the impaling, while impaling, the nucleus must be correctly aligned for total occlusion. Look at the arrow. This portion of the phaco-tip is actually not properly occluded, and because it is not properly occluded, we are not going to get a good chop, because the hold is not good. And now the nucleus is rotated and aligned in a manner that the bevel of the tip is actually in parallel with the edge of the fragmented portion. And so now the hold is good and we get a good chop. If the probe is superficial, the hold is going to be weak, and the slip can slip and injure the rhexis. This is a surgical video and stop and chop. So we first do a good trench, 1.5 phaco probe, and then we divide the nucleus into two halves with the help of a probe and the Sensky hook, and impale the one half properly with proper alignment and get a good chop. More than 2 or 4 or 6 divisions can be made according to the hardness of the nuclei. And at the end of the procedure, once we are happy with the number of fragments we have achieved, we can take away one piece by one easily. Thank you for your kind attention.